Okay, good morning, everyone. It is February 10th. This morning we have Margaret Fast talking about urology basics, and we're going to go ahead and get started. Anybody at home, again, if you can mute your screen, that would be awesome. But write in the chat if you have any questions. We got everybody. I'll look back at that. Oh, now we got Dad's iPhone.
Mom and Dad are here.
Okay, I got Jamie, Mike, Jason.
Yeah.
Hey, Mom. Hi, Mom and Dad. Who's Mom and Dad?
Okay, I think, can you guys write in the chat or let us know you can see our PowerPoint? Just let me know yes or no, if you guys can see it. Anybody?
I thought of that. I was like, oh, we didn't think of phone call part of.
So she's been just handing them out to everybody.
Yeah.
It works out. That when we have in service, it's like you know, wait like service time.
Okay, we'll go ahead and get started, and if anybody pops up,
Okay.
it'll show on.
Okay.
Okay.
All right. Good morning, everybody.
Good morning.
All right, Trisha. Let's see. Do I have to do something to make it advance?
That's probably good. Oh, I
Just-
just hit there.
Okay.
Yeah. I think if you do, you can look at those too.
Oh, there we go.
Do you
Okay.
have notes that you need to see?
I have them. I've printed them off
Okay.
just because
Okay, I can.
it confuses me to look at notes on the PowerPoint. Yeah. So there's our objectives. We're just going to talk about some basic urological procedures and how to care for them. So little anatomy lesson for you guys.
We can see. Okay, cool.
Urology usually starts, or at least the docs will tell you, I don't do the kidneys, but I do the kidneys on down, right? Now, having said that, nephrologists manage medically the patient. Urology would manage a kidney patient surgically. So there are urologists that remove kidneys or do partial nephrectomies and stuff like that, like Dr. Ambani, Kathenberger, those guys. But for the most part, urology covers from the ureters down. So you remember, kidneys make urine. Ureters are the tubes that come from the kidneys and go down. They move urine by peristaltic movement. Kidneys are always making urine, so there should be, as long as your kidneys are working, urine flowing into your bladder. The ureters attach kind of to the back of the bladder, and they're tunneled in there, which prevents reflux back up into the kidneys, which is hydronephrosis, which is a bad thing, right? Yes, very good. So once the ureters get to the bladder is just kind of a floppy vesicle is the old word for the bladder. So something that holds fluid. And as the bladder fills with urine, the normal capacity is about 300 to 500 mLs. We get the urge to void at about 200 to 300 mLs, as long as everything's working normally for us, right? What stimulates us to void is the pressure in the vesicle or in the bladder increases. Nerve fibers that are located in the sacral area of your spinal cord get, hey, pinged, the pressure's getting up, it goes on up to the brain says, oh, it's time to empty, sends that signal down to you, and that's where you will feel that your bladder's full and you have to void. Once that happens and you still have control over everything, your internal sphincter relaxes and then you void the urine out the urethra. Very simple. I think we got everything there. Yep. Oh, one thing I do want to point out on the male anatomy, and this will become important later, is we can see it's kind of at a right angle, that urethra, right? And then you've got that prostate right there. We'll talk about that a little bit more later on, but just kind of remember that picture. All right, so the first procedure is a TURBT, which is transurethral resection of a bladder tumor. And they do this for bladder lesions. They want to biopsy it or perhaps remove it or fulgurate that tumor, which means they just go in and burn it, to be quite honest with you. And of course, they're doing this under anesthesia, so you're not going to feel that. They use a cystoscope or cystoscopy to do that procedure. And a cystoscope or cystoscopy is where they take a scope that has a camera at the end, goes up the urethra and into the bladder. Very common procedure. They do it in the urology clinic all day long without sedation. So, yeah. It's If you've ever had a Foley catheter, that's what it feels like. So it doesn't hurt. It just is a weird pressure feeling, having had a Foley in my past surgical history. So, but anyway, obviously in the OR, it's a little bit bigger procedure. So I'd like to put it into pre-op and PACU concerns and considerations. So for pre-op, they're worried that they're going to have cancer, right? Because they don't know what that lesion is until they get the biopsy and get the results of it. So they might be a little anxious and worried about that. You know, some calming effects are nice. In the PACU, we're going to worry about pressure points from positioning in the OR. And I do have a picture later on of the lithotomy position, which is a very common position in the OR. So we'll talk about that. Once those folks come out, you're going to monitor your catheter patency. They may need CBI or continuous bladder irrigation. We're going to monitor the amount of the output and the input from that and what the color of the urine is. Pink's okay, dark red is not so much okay. We need to do what to fix that? Speed up our CBI. Yep. Okay. And you're going to want to remember, we're putting a lot of fluid into this patient. So if I'm one of those, older folks who don't have a lot of body adipose tissue anymore, or whatever my issue is, I can become hypothermic pretty quick. I can hemorrhage as well from this, and electrolyte imbalances from the amount of saline and bladder irrigation that you're using on your patient. Okay. For CBI, I talk to urology because I know, they come out and they give you a report and you're like, how much is infused? I don't know, right? All the time. So what they said is it doesn't have to be as accurate as, say, like, somebody who's in heart failure. What I would recommend is right then and there, you figure out where you're at with your bags and you go from there. All right. And then you know what you've got. Exactly. Yeah, basically. Transurethral resection of the prostate, which is called the TURP, or the HOLIP. We don't see the HOLIPs too much here. And in fact, Dr. Dow, who is the expert at doing HOLIPs, only does them out at Chelsea, believe it or not. But what the TURP and the HOLIP are for benign prostatic hypertrophy. This affects men. Everybody pretty much over 50 will their prostate starts to enlarge. But for some gentlemen, it just gets to the point where they can no longer void, or they have dysfunctions from voiding. They get a lot of frequency. I got to go. And then when they go, just a very little bit amount comes in. And then, 20 minutes later, anybody who's been with grandpa has to go to the bathroom again, right? And that's because they're not fully empty in their bladder. So those stretch receptors are saying, hey man, what's going on here? Let's see, did we get that? Okay. So what they do in this procedure is they use a resectoscope. They go up the urethra, and there's two ways to do it. The surgeon then resects that prostate tissue. The bladder is distended, and they can use up to 12 liters of fluid when they're in the OR. So again, thinking about hypothermia, electrolyte imbalances later on will be important. Okay. And that is the TURP part. They have it, the resectoscope has a special device on it. It's a wire that heats up, and they actually just kind of scrape that prostate tissue. Good thing for anesthesia, right? They're your best friends when you're going to the OR. Dr. Dow, however, does it with the laser, and that's the HOLIP part. That's the helium laser enucleation of the prostate, is what HOLIP stands for. These folks will come out with those big three-way, CBI catheters, but the big part on that to know is that balloon holds 30 to 50 mLs, and the balloon is used to hold pressure. They always have it on traction, and they're trying to put pressure on that to keep that prostate from bleeding because they've been in there irritating it. So that's the reason for that.
How does that cause to not bleed?
Well, it just puts pressure on
So
the
is balloon
area.
above the prostate?
Yeah, it is,
Oh,
but it's still
okay.
putting kind of pressure on it. But good question. Yes.
I don't know if there's people trying to get in on Zoom yet. Sorry.
No, that's cool. All right, so some little notes just to know. TURP is limited to prostates less than 100 grams, and the urologist can go in, they'll do an MRI, and they can see how big the prostate is. So you can only do a TURP on 100 grams or less. HOLIP can be done on any size prostate, but the HOLIP requires a little bit more expertise as far as the procedure goes. So not a lot of urologists will do it. And Dr. Dow here is our specialist at that. HOLIP has less bleeding, and most can stay on their blood thinners if they need to. So another advantage of the HOLIP.
Do they both get CBI? HOLIP and TURP?
As far as I know, yes. because I've never, to be honest with you, I haven't recovered a hold up.
I don't think I have either.
Yeah, because they don't do them here. They do it out at Chelsea. They do it as an outpatient, so they might not get CBI.
Right.
Yeah, that's a good point. Let's see, we talked about that. We talked about, oh, if I become, what electrolyte you think I'd worry about with that much bladder irrigation?
Sodium,
What happens when I get hyponatremic? What kind of signs and symptoms are you looking for?
decreased sense.
Mhm. What else? So you're looking for tremors, confusion, you talked about that. If you don't recognize that, the patient can progress onto neurological devastation, have seizures, like status epilepticus. You can also cause vascular collapse, so hypotension and things like that, if it gets that far. So we talked about CBI and what to look for, and we talked about all that. Okay. So pre-op concerns, both of these procedures have the potential to cause incontinence, so leakage of urine. Gentlemen also, not only gentlemen, but for a lot of gentlemen, having the thought of a Foley catheter is enough to make you, not want to do this and put it off, but they do go home with Foley catheters and they'll have them in for a little bit. And they will leak urine afterwards for a little bit, especially the hole-ups. They'll leak for up to 3 or 4 months. So not something to look forward. PACU, pressure points again from positioning, catheter maintenance, traction and paints. We talked about all that. Eyes and nose, be careful with your diuresis and how much are urine color, and then hemoglobin, hematocrit, and electrolytes. PACU. Prostatectomy. We do this for prostate cancer. This involves removing the entire prostate as well as any involved lymph nodes. And depending on how far, if it has metastasized, some of the pelvic organs, the rest of them can come out too, depending on what's going on. Hopefully they found it quicker though than that. Patients will have a catheter for a little bit after this, and they will have potential for impotency, incontinence, and continued issues afterwards. So it's not like, the most joyous news to find out you have to have your prostate removed for a lot of gentlemen. They can do it either by an open approach, retropubic, or perineal, depending on what they think they're going to find. And they do MRIs on these folks, which show you a lot, but don't show you everything. So sometimes it gets more involved than what you think it will be before you go in. They can also do it laparoscopically or robotic assisted. And I have some pictures I want to show you in a minute here. Exactly, and how much they have to remove and go in and dissect. Great question. Yeah. So pre-op concerns, impotency, urinary incontinence, and cancer, of course, because they already have prostate cancer and where it's spread to. And then PACU is going to be similar recovery stuff as the TURP and the hole up, and then the catheter maintenance. All right. Ureteroscopy. This is just a picture of a renal calculi in the ureter. And the scope that they use goes up again, urethra through the bladder. They get back up into those ureters, go on up, and they can grab the stone sometimes with a basket and pull it on out. Just a little break in the action here. This is a lithotomy position. Where would I worry about pressure points on my patient? Heels, yep. Yep. So should I leave all my patients laying on their back and not turning them and not looking at what's on their back and stuff? So, well, it is, but this is just a better, this is an advanced lithotomy position. Yeah, shoulders, exactly. Back of the head, right? Depending on how long you're in that position. These are obviously a little bit more than the stirrups we use that we're used to from the OB-GYN's office. These are really like padded and that kind of stuff. And they have to, be careful when they're moving the patient's legs and stuff, especially if they've been up in that position for a while. So the OR nurses, that's part of their gig is positioning and how they get these patients and how they pad and all that kind of stuff. And as a clin spec, I get to look at all the pressure injuries because of positions like this and what we have to do to help kind of prevent some of that. But in the PACU, our job is looking at the patients, not only surgical sites, but flip them over and look at their back, okay? All right, we'll plug for that. All right, ureteroscopy. So treatment of kidney stones is done either with ureteroscopy with laser lithotripsy, or they can do the percutaneous nephrolithotomy, and I can never say that, so PCNL. So the first one, the ureteroscopy with the laser lithotripsy. The laser lithotripsy is the breaking up of the stone itself, depending on how big that stone is. Then the ureteroscopy, they take up, like I showed you in that other picture, grab parts of the stone that they can get and remove as much of that as they can. All right. And then the, what else do we talk about that? PCNL is a little bit more involved because you will have an incision in your back. Then they go into the kidney and retrieve the stone that way. It all just depends on how big the kidney is, or how big the stone is, and where the stone's actually located. The stones can be in the kidneys, they can be in the ureters. The ones in the kidneys, patients don't feel so much, but those ones in the ureters, when they get stuck in the ureter, that ureter spasms, and that's that pain they get. And not only is it flank pain, but if it's in the ureter, it can be down into the groin and stuff like that too. So always ask, pre-op, are you having pain, and where's that?
So PCNLs are what's in the kidneys.
Yeah, they actually go in, they'll make an incision in the flank and go into the kidney itself and retrieve that stone. All right. And then the surgeon may place a stent when they're done. 9 times out of 10, they will place the stent. And what the stent does
From a PCNL?
from both, they can do it for both. What the stent does is, you can see it here in the picture. It's a silicone, it's real soft, like silicone device. It's not hard. It has curlicues at each end. And what the curlicues do is help keep it in place. Helps keep it in the kidney and in the bladder. It also keeps the ureter open so that if there are stone fragments, they can move down that and be expelled via the bladder. Also helps when the ureter spasms, because anytime you go in there and dig around, things start to spasm. So this helps keep the ureter patent, okay? Now, when you're caring for these patients, a lot of these folks have had kidney stones. There's a term for and I can't remember, a stone producer, I think is, some patients are just more prone to have stones and have had multiple stones over their course of urological history. So they are quite concerned about the pain that comes with it and pain management. So you'll hear them talk a lot about that. And they don't like the stents either, because the stents can be uncomfortable. But I can give you some tips here in a minute on how to help them manage those a little bit better, because a lot of times they don't drink enough fluid. But so there'll be a lot of talking about the stents, and I don't really want to do this, but I got to, because the pain from the kidney stone. In pre-op, you'll hear that conversation. In PACU, sometimes what can happen is these stones are infected. They go up there and they stir things up. Patient comes out, they're doing okay, but their heart rate just starts creeping up, their respiratory rate starts creeping up. What do you think's going on with them then? They're getting septic, exactly. So the challenge here is, are they tachycardic and anxious, breathing fast because they're in pain, or are they getting septic? So that's, good astute nursing assessment to kind of keep an eye on that kind of stuff. And if you're treating the pain and they're still continuing to be tachycardic and increased respiratory rate, all those signs of sepsis, don't wait for their temp to go up, because that's one of the later things. Start to get anesthesia involved in the service and to say, I'm a little bit worried about this person. We might want to think something else on this. So for pain control, they do try to very much minimize the opioids for these folks, especially the stone producers, because otherwise they're chronically on opioids, right? Toradol works wonders if it's used correctly. You just have to be careful though, renal insufficiency or GI bleeding history, you can't use the Toradol. The other meds that they give, the Flomax, the Pyridium, all that stuff are adjuncts that help relax. The Flomax relaxes the urinary system so that things kind of mellow out. The Pyridium is a bladder anesthetist. So it's, I'm going to admit Jen Webb into the Jessica. Okay. Oxybutynin is another one that helps relax the urinary tract. So encourage them to take those meds on a consistent basis. Don't wait till you're in pain or uncontrollable pain to start to take that. So they should be taking those around the clock. And we'll tell them that in the
Because I think they're
too.
labeled with PRM.
They shouldn't
Especially, I know Pyridia does.
Yeah.
Yep.
Do they?
Yep.
Yeah.
So bad on the urologist, because we'll tell them in the clinic, because I used to work in the urology clinic, that's where I'm getting all this stuff from. We'd tell them after your surgery around the clock for the first couple of days, it's just better for you and you'll feel much better. Okay. We worry about electrolytes, of course, because they're in there dinking around. So for the stents, they need to be drinking about 3 liters a day. And they'll tell you, oh, I drink a lot. And so my next question is, what's a lot, right? 2 big glasses of water. That's nowhere near enough, right?
Kind of hard if you're not thirsty though.
It is, but I'm telling you, when you talk to these patients, to tell them that drink your fluids, take your meds, take a warm shower or use a heating pad or a warm water bottle, whatever you use. Those simple things, you'll call them back like 3 hours later, I feel so much better. And it's amazing. And they'll push back. Well, a warm shower is not going to do anything for this. I'm telling you right now. I'm like, just give it a shot. You know what I mean? Drink a lot of fluid, keep up on stuff. And I'm telling you, you'll feel so much better. So when you're doing your discharge teaching, something to think about when you're sending those folks home. Yeah.
Sorry, I don't know.
No, you're-
There's
Water
people
is
trying
in
to join.
Half a gallon, like the half gallons of milk. How much is that? Because it's 64. Okay, so how much is, so liters, 1,000. Oh,
It's
so
almost always like it comes to
Yeah, it's a lot. It is a lot of fluid. It really is. And it sucks to drink all that, but it will make them so much better. Because what happens is if you get dehydrated, you don't have enough fluid in there, that stent rubs against the ureter. So while it's keeping the ureter patent, it's also irritating things in there, right? So makes it worse. If they have to do their stent removal at home, the thing to teach them is, and so let me backtrack a little bit. They'll put the stent in one of 2 ways. Either the patient can remove it at home, or they come into the clinic and the doc does a cystoscopy and takes it out in the clinic 3 to 5 days later. If they're going to do it at home, you'll see the stent attached to either the catheter if they have one, though most of the time they don't, or you'll see a string hanging out. That's the string from the stent. And what the patient's instructed to do, drink a ton of fluid about an hour before, take some over-the-counter pain meds, or if you have any of your whatever opioids left, take all your urinary stuff about an hour before. When you're ready to do it, go stand in the shower under the warm water for a few minutes, get yourself relaxed, and just, as gross as it sounds, start to urinate and pull the stent out. It comes right out. It's, like I said, it's a soft silicone, and they pull it right out and away it goes. So we'll also take it out in the clinic if they're not willing to do that. Most who have done it a couple of times or at least once are like, fine, I'd rather do that than come back into the clinic and have it done. Okay, so good discharge teaching for that kind of stuff. All right. Our next topic, a little bit more involved, are the cystectomies. These are the patients who have really, really bad bladders. They remove bladders for a number of reasons. I have bladder cancer. I have chronic UTIs. I have failed all therapies for incontinence and I just leak urine constantly. And it really sucks being wet all the time. I unfortunately have never had to experience that, but nurses and teachers are the worst offenders for not emptying their bladder on time. And over the years, your bladder is like, I'm done with this. And now I'm just going to leak all the time. All right. So it's all a bunch of physiology back there. That's a little bit much for this lecture, but if you ever get into urology, you'll hear about it. And then neurogenic bladder, and neurogenic bladders are folks who don't have innervation from the spinal nerves. So spinal cord injuries, spina bifida patients have a lot of urinary tract issues. So they might over the years have had dysfunctional voiding, never emptying their bladder, high bladder pressures, and now their bladder is just completely failed. And then the last indication is interstitial cystitis, which if that's not a real common diagnosis, but it's one of those that it's usually in women, but it's like 4 to 1 women to men for this. And what they have are like chronic feelings of needing to have urge to go to the bathroom all the time, feeling like they chronically have UTIs. And when you dip their urine or do their urine, it's negative. And they just constantly feel like they have a horrible diagnosis to have. They don't really know what causes it. treatments for it are very varied. There's a lot of urologists don't even feel it's for real, but it is for real. Believe me. Well, I don't know about all that, but you might be onto something there. Plus, there's no good way to diagnose it. There's no, like, you might go up and see a little bit of inflammation in the bladder if they scope them, but there's nothing really to show why they're having the severe symptoms. And it's an awful disease. So they try diet, they try different medications. We do bladder installations of really weird medicine. We put like 5,000 units of heparin up their bladder for these installations that we do, plus some Medrol, some antibiotics, all kinds of crazy recipes that they have to try and treat these folks. And they have to have these installations once a week. So, you know, you do that for a while and you're like, okay, I'm done. So I need my bladder out. I mean, it's an extreme, but sometimes it does come to that. Okay. So the surgeon can divert urine a few different ways. You can have an incontinent or a continent stoma, or you can get a neobladder and void on your own. And I'll talk about each one of those. These are complex, lengthy surgeries, and a lot of these patients have a lot of other comorbidities to go along with them. As you guys, let's see.
Is that one of the reasons why they do that bladder distension?
Yes, hydrodistension. That's for interstitial cystitis. Great. And you know what? I thought about that, putting that in here, and I was like, we don't see those too much because they do them on the outpatient a lot, or ambulatory sites a lot. But yes, that's a cysto with a hydrodistension, and that's why they do it. It stretches the bladder. It does sometimes bring relief for some of those folks. Great question. All right. So the first one that they do, the cystectomy with an ileal conduit. This is where they take part of the bowel, so the ileum, they'll take a section of it. They take the bladder out. They take the ureters, attach it to that section of the bowel, bring that out to the outside, and now I have a incontinent stoma that I have to wear a bag over, and I just drain urine all the time. So this is a picture of the continent stoma. These are, and they do put stents in there initially after surgery, so that's what you'll see in that urine bag, those things sticking out. You're like, what the heck is that? They're stents for both their left and right. And your sister told me what color is each, and I can't remember. So
I don't know either.
Christy was quite a bit of help on one of these lectures for me. She offered some great insight. She worked on 5C for a long time, so she got to know that patient. But that's okay.
So there,
Next time it's
there's
urology.
two different colors. It means like right or left.
Yeah, I believe so. Yeah. So anyway, so this one, the bag's off, obviously, but you can see where the disc for the stoma and stuff was. I just threw that picture in there because that's a picture of a laparoscopic surgery. Yeah. So I wanted everybody to appreciate the fact that, yeah, you come out with these little teeny tiny incisions, but that's what it looks like in the OR.
And then you move them around.
Well, and that, yeah, the surgeon is not looking at this. They're looking up at the screen while they're doing their stuff. With all these ports, they put different things into it: grabbers, scissors, scalpels. That abdomen, if you look at it, it looks distended, doesn't it? It's full of CO2, so they can move stuff out of the way. So you wonder why you think laparoscopic's great, and it is, it really is, but it still hurts because of what you see there. I'm glad you guys like that picture. I put it in there for the effect. I was like, just so you kind of get the background of, yeah, exactly. All right, the next type of cystectomy they can do is with a pouch. And again, they take a part of the small bowel and make a pouch on to store the urine. They take the ureters, attach it to that segment of the small bowel. There's your pouch. There's a stoma on the outside. But the nicer thing about this one is you don't leak urine out of this one. You can catheterize this one. So a little bit more control and not having to wear the bag, right? So this way you can have a little bit more of a lifestyle if you have to work and that type of thing, and it makes your job a little bit easier. I know a police officer, I took care of a urology clinic who had one of these. So obviously you can function at a very high level. Yes.
Will they do this for Tropinoff? Or is that
With Tropinoff, it's about the same thing. Yeah, and in kids, that's a great point.
that's just the bigger?
Exactly. For children, if they have to have these, so these would be those, you know, kids with spina bifida and myelin meningocele children. They will do the opening in the belly button till it's hidden. Yeah. Yeah, the umbilicus. You catheterize your umbilicus. Yeah.
Maybe when you came
You can't even touch inside there, it hurts.
Well,
Oh, so hard.
I don't know. I took care of a couple kids too. They come into when I was doing urodynamics and they, yeah, let me calf myself, you know, the 8-year-old, you're like, wow, this is amazing. But they've grown up with it.
All the
So
ones I've seen was on the side.
most of the adults they do on the side. You won't see the belly button too often, but if it's, you know, here we work at a tertiary care center where we have children who are born here and are followed through their career. So you might see it, you know, in an adult too.
If you're paralyzed, you don't have to feel it. Yeah, go for it.
All right. And then the last one is a cystectomy with a neobladder. This is where they take, again, part of the small bowel, they use it to resect and make a new bladder. This patient can still void via their urethra, but they have to do abdominal voiding. So they increase their abdominal pressure to pee. They can't feel that their bladder's full, so they have to kind of do it timed, you know, every couple of hours, they have to go void, but way more control and, you know, cosmetically a much better thing if they can do it for it. Now, how the surgeon goes in and decides which one gets what procedure, that's beyond our scope and my scope, I don't know. We'd have to ask Dr. Stoffel, who does a lot of these, what the decision-making process is. Probably goes along with comorbidities and all that kind of stuff. And have they had multiple abdominal surgeries, what type of adhesions, all that kind of stuff that's in there. All right, did I cover everything? So care of these folks, pre-op concerns, they're going to be concerned about the alterations in their lifestyle and body image. It's a big concern for these people. They've been dealing with this for years most of the time. This is the last resort that they have, and they're not usually too excited about having this procedure done, right? So empathy goes a long way. PACU concerns, these patients can be pretty sick. We need to maintain the stents, the assessment of the stoma. We saw that stoma, that was nice and pink, wasn't it, and moist. Even a titch of blue on that stoma is bad news, and we need to get the service down here to take a look at it because that means something's already going wrong with it, all right? So good assessment skills is good for that. And then of course our surgical sites, hourly eyes and nose, we absolutely have to do it on these folks. Fluid and electrolyte monitoring. So these are the urology patients that come out that you get labs on right away so that you have baselines after surgery. They can have an NG tube, they can have an art line, they might have a urethral catheter still just to keep things patent for now. Sometimes they close them from below too, depending on what's going on, but that's a surgeon decision. Pain management is going to be an issue because any abdominal surgeries hurt. Take my word for it. Haven't had a C-section. You don't realize how much you use those muscles. So you got to turn in bed or something like that, right? And then urine will have mucus in it, and a lot of mucus. Why is that? Very good, because we use the bowel to make this neobladder or the ileal conduit or whatever. So not so much post-op, but later on, we have to encourage fluids for these folks and that type of stuff to help keep some of this mucus under wraps. Okay. Augmentation cystoplasty. This is where we take, they want to increase the bladder volume for some reason. Sometimes people who have radiation cystitis, interstitial cystitis, again, if their bladders can be really small sometimes and very irritated. So if we can increase the size, at least they don't have to void every half an hour. Now maybe they can go to every 2 hours, a little bit more normalcy for these overactive bladders. So again, nurses, be careful. Go empty your bladder when you feel the need. I know it's challenging sometimes, but we don't want to be taking care of you in 20 years, having some of this stuff done. And your teacher friends, encourage your teacher friends, especially with the little kids, because how can you leave? I always think that when I help at my son's school, you know, she just can't run in the bathroom with 5-year-olds running around, right? You can't leave them alone, for Christ's sake. So yeah, I always feel bad. Bowel segment is anastomose to the bladder dome, so the top of the bladder, and you can see it sutured in there to kind of increase that capacity. Pre-op concerns, they might be worried about having to catheterize because they probably will, at least initially, until things settle down in there. So a lot of these folks have been self-cathing at home for years anyway. So
Did I miss it? But where'd they get the skin from?
the skin, it's the bowel. Yeah, it's part of the bowel. That's what. Yeah. Mhm. Let's see, PACU, eyes and nose will be a concern. Watching that kind of stuff, they'll probably have a catheter, post-op fluid and electrolytes. They might have an NG tube. And then we talked about the catheter already. We don't see too many of these, but they do them. All right, kind of different focus now, the sacral nerve, sacral neuromodulation, or the interstim. And the interstim is a device that sends electrical impulses to the sacral nerve to help control some of the urinary frequency, urge incontinence, or folks who, for whatever reason, don't get the innervation to say my bladder's full. And they can, you know, we've all seen those people with 1,000 in their bladder, and you're like, you didn't feel that? I'm like, nope. So, but what they do is it's a 3-piece device. It has the implant, the lead wire, and then the external controller. And the external controller looks like an iPhone a lot of times. Let's see, we talked about that. The batteries will last 5 to 7 years, so they will have to come back eventually and get them replaced. The surgery is done in 2 steps. The first step, well, first of all, the patient has to have tried and failed multiple treatment modalities for whatever their issue is, the interstitial cystitis, the voiding. We do teach patients. Sometimes people have learned to void. We call it voiding dysfunction. They're embarrassed to go to the bathroom. They hold it too long, or whatever it is. There's sometimes some psychological things that have to be worked out before you can do this. Teaching people to void every, you know, sometimes with this urge incontinence, you got to go every 10 minutes. Well, what we do in the clinic before we try and put one of these in is say, okay, today you're going to go 15 minutes. Tomorrow you're going to go 20 minutes, 30 minutes. So behavioral modification, because if you're chronically thinking about your bladder, you're chronically going to have to go to the bathroom, right? If you think about it. And it just overtakes things and it gets out of control sometimes. So this is 2-stage procedures. You guys probably well know. The stage 1 is they put the wires in, they put the controller in, or the implant in, the control box itself. The neurostimulator is what they actually, the official term for it is. And they bring that lead wire out, and then they kind of make sure it works, right? They give the patient a couple, 3 weeks, 4 weeks, whatever it is, to make sure that this is actually going to work. Because that lead wire stimulates those nerves when it's time to go. And they set that controller up to do that for the patient. The reps have worked with these patients, and we also see the reps come down here afterwards and set things up for them and make sure the patient knows how to handle it when they go home. And then step 2 is when they come in and say, okay, everything's working great. We're going to implant everything internally. So they take the wire and they put it all in and everything's good to go. Okay. So pre-op concerns, will it work? How's it going to feel to have that thing in my back and to have those wires, and, you know, that kind of stuff can make folks nervous. PACU, we talked about the rep coming out. Dressing changes do need to be done every 1 to 2 days. So teaching the patient how to do that without ripping the wires and stuff out, just gently change the dressings. You want to keep them clean and dry. No showers until the 2nd stage, because you've got that wire sticking out. You don't want to send somebody in the bathtub or the shower, so they'll have to do sponge baths till then. And then they also have to let other providers know they have this implanted. And one of the big drawbacks for this is no MRIs. So if this patient has a history of back pain, or there's any thought process of getting MRIs in the future, this would be contraindicated for that patient.
So then obviously make sure that the cords are long enough for any bending.
Yep. Yeah. And what happens inevitably, they get that implanted and they slip and fall on their back, right? Oh, we've seen it so many times in the urology clinic. So then they have to call us and we have to come in and they interrogate the device and can figure out if the leads are still where they need to be and that type of stuff. But yeah,
What happens when case 1 is not working?
if it doesn't work, they take it out and then
How do they take it out?
they'll go back and remove everything in the OR.
Because I had one in pre-op for phase 2.
Oh,
Everything comes off down. Everything comes off.
Thank you.
There's some socks going on. And that's for shoes, other shoes. And
You're going to have to go. Everything.
yeah, somebody's not. So that was not good planning on the part of urology, obviously. Communication. Why he would have been
Keep the
scheduled.
mask on though.
I don't
We
know.
would prefer it.
Yeah, but. Like you said, I think it shouldn't be removed in OR, right?
Mhm.
But he just went home.
He kept the device in. I see. Okay. So probably because the planned surgery was to finish the procedure, they have to rethink that and reschedule a different procedure to remove it, would be my guess. But I don't know. That just sounds like a total communication breakdown.
You've had that too, right?
Really?
Many times you have this. They come in and we give them Venco, we give them everything and then they go.
So when you're asking them what they're here for, what do they tell you? And then he just said it doesn't work and nobody.
And then the surgeon comes.
They don't even know that.
Wow.
It's not that it wasn't working completely, but they were kind of wishy-washy on the decision.
Some of these patients, when they leave, they already have their phase 2 appointment already set up. When you print their discharge, it already tells you when they're coming back to have it placed. They clearly don't even know if it works yet.
Right.
So
Interesting. Yeah. I don't know what to say about that, to be quite honest with you, because that's obviously not a good communication with their provider and the patient. So yeah, as far as scheduling the second phase, I'm okay with that, with the understanding that you would be seen in the clinic before that and have a discussion as to whether it's working or not. So
On their discharge paper, do they have an appointment already scheduled or is it just the second procedure?
I feel like there's both.
Okay.
okay. Yeah.
That would be, obviously, then they could come and like check it in the clinic, but to just bypass that and schedule the second procedure, but maybe people cancel or whatever.
So
Here.
not to bias your mind against urology patients, they can be a challenging group of patients to take care of because they do have these chronic issues and they get a little grumpy and they get mad at the providers. And then they're like, yeah, I'm not even going to the clinic because they're not going to help me. Well, unfortunately, sometimes none of this works for these people. It just stinks being that way. You know what I mean? And it does. And you just feel bad for them. But on the other hand, they do kind of have to do some of the things they're supposed to too. So just an FYI. Real quick, the slings, there's mid-urethral and pubovaginal. They do have a male sling for after prostatectomy, and they use surgical tape and kind of prop things up. The mid-urethral sling uses mesh, and we all know mesh causes issues, can cause issues later on. So they're not doing it, I don't think, as much. And then the other one, the pubovaginal, they use the fascia to actually pull things up. That can lead to infections and chronic pain though. So the slings aren't the best thing to happen either. But again, if you're constantly leaking urine, you're desperate and you're going to try pretty much anything at this point. Okay. For the slings, you will have, they do them for stress incontinence and urge incontinence. So constantly feeling like I have to pee or I cough, and every time I cough, I get wet, and that, you know, over time gets old too. Pre-op concerns will work. They will have to catheterize probably for a few days afterwards at home. So they get nervous about that. PACU concerns. If they have a catheter, we want to monitor the color of the urine. They might have vaginal packing depending on what's going on. Intermittent straight cath teaching and urinary retention. Hopefully they've done that already in the clinic. Urology is usually pretty good about teaching that. I know OB-GYN not so much. And that's where you might see some of that. Just saying. They will have urgency, and that can last for weeks. So sometimes it takes a long time to see if the sling's actually working, and they might have an overnight stay. And I don't think we see too many of these. I think they do a lot of these on the outpatient side because these are pretty generally healthy people. They just have unfortunate urge incontinence or stress incontinence. All right. An AUS with an artificial urinary sphincter. Again, we don't see too many of these, but this is used for male incontinence. And what they do, it has 3 parts. It has a reservoir full of fluid that goes up into your kind of in your abdomen or pelvic area, just sits in there, floats around, attached to a primer. This is a button. That's a primer button that's attached to the cuff that goes around the male urethra. The normal thing on this is to have it inflated. So it stays inflated, wrapped around that urethra and closes the urethra. When the gentleman has to urinate, this is in their scrotum. They feel for that button, they push the button, it deflates the cuff and allows them to void. And then a couple, 3 minutes later, automatically will inflate itself. The thing about these though, is you have to know that it's there, because if this guy's driving down 23 and gets schmucked in an accident and ends up in an ER, you don't want to try and cath him, because that cuff's going to be inflated and you're going to be banging against that and you're going to cause a bunch of trauma. They're supposed to wear a medic alert so that you know it's there. But, you know, usually in a trauma, you're not feeling some guy's scrotum to see if they got anything floating around in there, are you? If you've ever worked in the ER, I never did. I do remember one trauma though. They were doing, she was having, they went to do, because in trauma patients, they always see if the sphincter is working for spinal cord injury. Well, they see plastic sticking out of her vagina. She had stashed her dope up there. So they had to pull this thing. That was the best one ever.
I've never seen one of these.
Yeah, they're not too frequent. They do work. But the problem is they often put them in 80-year-olds, and you have to have the dexterity. And all right, so it's kind of gross, but if you've ever felt the male scrotum, it's a little squishy, and that thing is just floating around in there. So you actually, what we teach with your left hand or your non-dominant hand, you grab this, and then with your other hand, push the button or squeeze, whatever you need to do. Yeah, and we have to come and teach. That was part of my job, was to teach these guys how to use this after they put it in.
It looks like it's taking its blood pressure.
You would think it would hurt to squeeze like that, but these guys don't care. They're like, whatever, you know what I mean? But anyway, so these pre-op concerns, this is embarrassing. They might have some skin breakdown because they do leak they will stand there and dribble constantly. It just stinks to exist like that, right? So anyway, they'll be a little bit embarrassed. They might have some skin breakdown. Vancogent, the fluconazole, of course, our usual cocktail. PACU, penile dressing is usually in place, so you want to maintain that. You will do nothing with this in PACU. They don't even activate it for 6 to 8 weeks after surgery. So it's just, when it's not activated, it's open, so they're still going to leak. So you'll want to pat them for that type of stuff. And then we talked about the urethral catheter. Okay, penile prosthesis. This is artificial penis. Again, 3 parts. That fluid-filled reservoir lives up here. The pump with the button is in the scrotum. And then the cylinders, there's 2 cylinders on each side in the corpus callosum of the penis. Again, they pump it up. This one doesn't stay inflated all the time. They inflate it as they need to. So it's kind of the opposite, where the gentleman will pump to inflate it. Then when they're done, push the button and kind of squeeze, and it deflates stuff. Devices placed for folks who have failed all treatments for erectile dysfunction. There are some other P&L issues that they might put it in for. Pre-op concerns, again, embarrassment, and protect their privacy. We don't all need to know. Think about how we work here. It's all curtains, right? Everybody knows what everybody's saying. We used to joke in the ER, we had our board like in the middle of the trauma bays. Trauma bay B and C always knew what was happening in the ER because we all stood there and talked about it, right? So just be careful. And then again, in PACU, don't bring all your buddies over to see the penile prosthesis, because A, it won't be inflated, and B, we don't need to show that off.
Is that silicone?
You know, I don't know for sure what it's made of. It could be. It's a soft material, yeah, that they use in that. The urethral catheter, they will have a catheter initially for us, and then compression dressing, they will have that on as well. And we already talked about our conversations. Penectomy, this is where we remove the penis, obviously a very traumatic event, and this is for penile cancer. And also some other times HSV herpes simplex gets out of control. A lot of these folks don't seek treatment because it's very embarrassing to come in and talk about lesions on your penis, right? And some of these gentlemen, especially the older ones, will not come in until it's way late, and now we have to do a total penectomy, which is not fun for anybody. So pre-op concerns, obviously, altered body image, and then it's cancer, how far has it spread? PACU concerns, they will have swelling to that site, so whatever dressing they have, looking at that dressing for bleeding, that kind of stuff. Pain control, big thing, and then catheter management on these guys too. We don't see too many of these either, but
I've seen partials.
Partials, yeah. There was just one the other day I saw on the status board though, so, and not a whole one, but a partial, but still, any, whatever. It's just very traumatic for these gentlemen involved and their families and everything. All right, suprapubic catheter. I know we all know what they are, but I just wanted to review them real quick. These are used for long-term indwelling catheters. So what they do is they actually go through the abdomen, put the catheter into this bladder and leave it there. Then attaches to a leg bag or drainage bag, whatever you need to do. These folks are folks who, for whatever reason, they have maybe a neurogenic bladder. They're not wanting to straight catheterize themselves anymore. Sometimes it gets to the point where they've had a urethral catheter so long because they've refused to do this, that the meatus and the urethra becomes, what's the word? Well, not hypospadia, because that's where the opening's on the bottom, but it becomes enlarged and just nasty, and you can't keep the catheter in. It's eroded, I guess is the word I want to say. Because people do, when you have indwelling catheters, they only change these every 4 weeks if you're at home with this. Yeah. And they usually come into the clinic to get it done. Nurses do change suprapubic catheters. You just deflate the balloon like you do on a normal one. You pull it out and you put another one right back in and hook all your stuff, fill your balloon, and away you go. Thing I want you to know about this, we just had a patient who was here for over 2 hours with a suprapubic, had no urinary output, was sent home. 6 hours later, still had no urinary output. Came to the ER, had some acute kidney injury because of that, had some hydronephrosis because of that, and no output was documented on this patient's chart, either from the OR or from us. So shame on the OR, shame on the urologist, and shame on us for not catching that, right? So that's why we're harping on these I's and O's so bad. This could have been really bad for this patient. And what had happened is, for some reason, he didn't have a regular catheter come out. He had a Cook catheter, which is one of those real small ones, and they had it hooked up to a stopcock. And in the OR, they had closed the stopcock and didn't reopen it when they sent him out. So you guys use your good assessment. Exactly. That's why he ended up in acute kidney injury, because he had hydronephrosis, because 6 hours later, the family's like, why hasn't he drained from his catheter? He did. He had a bag. Yeah. So I know.
Take it out. Then
Why he had the Cook catheter instead of a regular catheter, I don't know. That's the part that confused me. But having said that, we're good nurses. We want to make sure we're monitoring our patients, and if something's not right, look into it. Any questions on the suprapubic? There, people, again, with spinal cord injuries and stuff will have these. They can get a little ganky. They don't always keep them as clean as they could. So yuck, but here we go. All right, what else we got? I think, come on. Oh, Coude tip catheters. So for those, you probably all know this, straight tip Coude. Coude is curved, and it's curved so it can go up underneath that male anatomy. All right, we can put Coudes in. We don't need a special order for a Coude. You just need to order and place a Foley catheter. So if you're putting in a straight in a gentleman who you think has BPH, so anybody over 50, unfortunately, potentially has it, and you can't get that straight in, you can go get a Coude, and don't go smaller, because the smaller you go, the less you kind of have behind that Coude. So you'd use a regular 16 Coude, just like you would, and you insert it with the tip of that Coude facing up. Right there. Hold the penis straight out. If you do that, that helps get rid of that 90-degree turn. And then that Coude can go whoop up under that big prostate and get in there. All right. And then you just inflate your balloon and care for it like a normal Foley catheter. Any questions on that? Because I know we've had questions about, can we put in Coudes? And yes, we can. Yeah.
as long as you do the P, like you said, you have to have the tip.
Tip up. Mhm.
I have not.
Doesn't do any good. Yeah.
I have had where I placed a catheter and I have felt catheter in their testicles. They're like coiled in there. What's that from?
That is making a false passage in their urethra.
Like we put it in and I'm like, what in the world? I could like see it.
Yeah, that's a false passage in the
Is it a
urethra.
fistula that they have?
Yeah, they got something bad happening in there. Yeah. So what'd they do?
I took it out and I called the doctor.
Yeah, that's I would do.
And it was no pressure. I
You didn't have any bleeding or anything after it?
No,
Shut up.
no. I'm really weird looking. Like a bowl of spaghetti.
Because the home care nurse put the catheter into the testicle and still in the bladder. He made it like 2 days because it still started leaking down into the testicle and coming out. The urine started going that way. So he was still having urine, but he didn't make it.
Yeah.
So that's the serious.
So if you don't get urine, what do? Pull it out and say something's wrong? Yeah, exactly. Because I've seen that happen too, because you could be in the urethra, you inflate that balloon and you just cause trauma in there. And yeah, and I've seen that happen before too. Well, I thought they were dry, Margaret. I'm like, there's always urine in your bladder. Unless you're like, have renal failure where you never make urine. But then there's really no need to put a catheter in, right? Because you don't have any urine to empty. Now, some people in renal failure do make urine, and we've seen that before. Right. Okay. Plug for the eyes and nose. I think I already talked about, gave you the story of why we're on this. So stuff to think about, not only your IV fluids, but your PO intake, any urinary drains, any drains of any kind, we should be checking hourly. Stomas, that kind of stuff too. Any questions, you guys? Okay, well, thank you.
Thank you. That was awesome.
You're very welcome.
I have a, concern. Yesterday I had an MA just come to my bedside and just dump my urine. And thank God she, like on the side, charted it, but I had told her, you have to be careful when you do it because this is a pituitary patient. I need to know how much urine you just took for the hour.
Oh, yeah.
So thank God.
Yeah.
She made it, like, she just dumped it and walked away. And I didn't know if she was gonna charge it or not, but then thank God I looked, she did.
Okay, yeah, I said for sure, because you got to know. Yeah.
Good service.
Well, thank you.
Great. That was a lot of
I
good.
really did learn a lot.
Good. I like doing that kind of basic stuff because even though it's basic,
Thanks, guys,
sometimes
for
we don't know the
zooming.
background of everything. You know what I
Right.
mean?
We don't
So,
know everything.
what's that? The
The
presentation.
PowerPoint?
Yeah.
Just the PowerPoint. I'll